Okay, so I liked very much the program this morning. There were a lot of new data, at least for me, on adherence. And if I had to summarize a key question or key factor I have seen today is that still the perceptions about medication and about adherence of the patients and our perceptions are still very far. We have to try to improve that, to try to listen better, perhaps, to patients, or to refine our perceptions about ourselves and our patients in order to improve a question that still has not been solved at all.
Mm-hmm. And that, to me, was also a striking thing. So first of all, it's great to have a full day of a symposium that's focused on the issue of adherence, because this is something that has been neglected in the past, and we're now spending a lot of attention, giving a lot of attention to this issue. And as Jose says, it's not just patient perceptions that are the problem, but it's looking at caregiver and even at psychiatrist and physician perceptions that are a barrier to effective adherence. And one of the slides that was presented this morning indicated that a significant number of psychiatrists, if they had a schizophrenic illness, would not take their medication regularly. And that is a bit disturbing. So it's good to, we've had some really nice presentations this morning. I think Wolfgang Fleischecker set the scene by emphasizing the burden of the illness of schizophrenia and the major contributing role to that burden that adherence plays. And then Stefan Harris from Germany presented some of the results from a very large survey that was conducted looking at physicians' perceptions around adherence, and this brought out again perceptions that were not always in line with what we believe is the evidence that we're aware of, that adherence, non-adherence is a major issue. Jan Scott gave a really nice talk around psychosocial interventions, myths of some of the interventions that may not be so effective and others that are effective. And then my colleague Jose also gave a fantastic presentation, a kind of a hands-on, practical approach to addressing the issues around adherence. So this afternoon we'll be focusing on the same issues, and it's wonderful to see a large audience participating actively, and it's really nice also to see the interaction that we're having from outside via the internet, from other countries that are also participating in this symposium.
Yeah.
So, Luca, what was the thing that was really interesting for you in this symposium today?
Well, actually, I enjoyed the fact that there was a lot of old, traditional, good psychopathology with new things, like all the genes and the aspect on brain volume. And those are very interesting.
A mixture of clinical and scientific knowledge, definitely. Yes, and especially as there was analyzed and compared with sometimes very different point of view, and sometimes also sharing the same type of conclusion. For example, for the very first presentation we had from René Kahn about the cognitive improvement and how we could improve it, what was the most important finding for you?
I think that he points out very much that difference in cognitive measurements requires a lot of troubleshooting, and that we don't have drugs that clearly are affective cognitive function even in normal humans. Of course, everybody will be taking them, cognitive enhancers, we call them. And we clearly need to then rechange our approach, probably.
And I think we were both impressed with this curve about the cognitive deficit, which is occurring very early in the process, which is not specific to patients with schizophrenia. It's also present in controls after 40, 50 years. And we have to admit that all of us are being concerned or will be concerned. But definitely for the patient with schizophrenia, the curve is much more important, meaning that they have a lot to lose for their cognitive abilities. And with this type of modifications with a high heritability, around 50%, it means that it's part of the disorder, but it probably doesn't mean that we cannot avoid this kind of decline.
Yeah, and I think you also pointed out this in your presentation. When can you really act to have a personal functioning and the relationship between all these cognitive abilities and the personal functioning? How early you have to then go in? Because, of course, a patient that has never learned to work, for instance, and now is in his 40s or 35, is already getting into that decline. And now it's difficult to get all the other, psychosocial education measurements.
Sure, the earlier we do it, the higher chance we have. You were probably also very interesting with this cognitive aspect of Hanekan regarding your presentation on the PPI, because PPI is clearly a more endophenotype on the research field, but it's totally linked to the cognitive aspects of the disorder.
Yes, absolutely. The thing is that if you are not able to select your major subject of attention, then everything else will not follow. Because if you're able to really focus your attention, then you can be educated, quote unquote. But if you cannot, let's say the ADHD as an example of those kids running around, they really don't have any focus on attention. It's difficult to then achieve the cognitive ability they might have, and they are not schizophrenic.
Sure.
So,
and what was also interesting in your presentation is showing that when you get to extended release, if you stop the treatment after subchronic exposure to the treatment, you might keep on a positive impact on PPI, which might be considered as a kind of impact on more protective for the relapse of symptoms or even a new episode.
Probably for this model in these animals with this drug, so with giving paliperidone at a slow release, they could be, at least in our hands, that's what we see.
And that is in accordance with Christophe Tessier's presentation, where he found that you might have very obvious benefit regarding side effects when you have extended release or even long-acting injectables. Not so easy to depict for clinical benefit on the symptoms level, but might be because it's more difficult to catch.
Yeah, on this I have a question for you that impressed me. He shows, Dr. Tessier, shows that you switch patient either from olanzapine or paliperidone or risperidone on paliperidone, and then you get better anyway. I would have expected a difference in this. I don't know what's your opinion.
Exactly the same as you.
Yeah.
Because usually when you keep on the same treatment, just modify the pharmacokinetic, you keep on the benefit.
Yeah.
And when you change the treatment, sometimes, you have different type of treatment response.
Right.
And then you might lose a little bit of these patients.
I would say this. I'm not going to go into the fingerprinting idea of a patient responding or non-responding to something. They should be eligible, as the audience said, because the audience said, I want to have symptom control and I want to have a steady then a functional outcome from the symptom control. But now you're coming from olanzapine, which is a completely different fingerprint and pharmacodynamics from risperidone, yet you get the same type of very similar good response.
That would be in favor of the fact that getting to a different pharmacokinetic with extended release would add a benefit which overpasses all the other aspects, such as the type of treatment, for example, we have.
That would be my interpretation.
It's really a very important part about getting to these longer-term treatment with a longer pharmacokinetic. Okay, then we had this splendid presentation from Andreas Meyer-Liedenberg about the genetics faced to these imagery in schizophrenia with these findings he had on the zinc finger and the COMT gene, and explaining that those vulnerability genes might not explain the disorder, but might be involved in a specific mechanism of way of thinking, cognitive aspects that might in some patients get to schizophrenia.
And especially the possibility that he even highlight on on developing medication based on this approach. It seems to be a very mechanistic approach, going back to the old times in which you have, let's not say a receptor, a drug, a model, but rather a genes or a system of genes and then modulating them. Of course, the brain is difficult because it's also a sanctuary. It's inside, it's protected by the brain-blood barrier, so it needs to penetrate. So bioavailability is also an issue sometimes. You can have a beautiful drug in vitro, but then in vivo is difficult.
Brain is difficult, but clinical science is difficult, as you shown also with the Inveritas case study, where we had a widespread type of response according to the questions we had, and sometimes a large change of the opinion of the attenders, which was really interesting too, because discussing together, pinpointing some points, usually make you modify your opinion. Yeah,
clearly colleagues around the world are asking us, giving medical education event like this one, or the pharmaceutical company or the regulatory, everybody, they're asking for better drugs. And they're asking for drugs that are not controlling so much the positive symptoms. They seem to be happy with what they have, and they seem to handle well. They're asking drugs for which we have not really developed a model, sensitive model. An animal cognitive model, an animal negative symptom model are difficult. Then you go into humans, are even difficult. So we clearly have a lot of work to do still. But this, I think, was a very good meeting.
Yeah, absolutely. Thank you, Luca.
Thank you.